Yeah, good morning everyone. So, the topic is association of keratoconus with eyelid abnormalities. So, I will be discussing this topic with a case. So, this was a 17-year-old male who presented to us with watering and photophobia in both the eyes, and also there was diminution of vision in both the eyes since many years. And there was history of some kind of lid surgery which was done, the details of which were not available few years ago. So this was the clinical photograph during presentation. We can see there is shortening of the palpebral fissure height and inward turning of the eyelashes. So his visual acuity in the right eye was counting fingers 1 meter, and in the left eye it was 20/40. The eyelids has a distortion and scarring at the lid margin, and they were inturned. In the cornea of the right eye, there was a full thickness scar with descemet membrane tear, whereas the left eye cornea was clear. Yeah, as we can see in the clinical picture, there was inward turning of the eyelashes and the scar in the right cornea. So the electrolysis was performed in this patient, which gave relief of the symptoms, and after that the corneal topography was planned. So in the corneal topography, as we can see in the right eye, due to the presence of scar, there was irregular topography, whereas the left eye showed the features of keratoconus, where we can see the infero-superior asymmetry along, there was thinning in the pachymetry map. The ASOCT in the right eye shows the hyperreflectivity in the center cornea with retracted descemet membrane tear. So the patient was advised for the scleral contact lens to know the visual potential of the patient. After the scleral contact lens, his best corrected visual acuity improved to 20/40 in the right eye and 20/20 in the left eye. Along with this patient, his younger sibling, the 14-year-old female, also visited to us during the same day with same complaints, and she also has history of electrolysis in both the eyes done for interned lashes. This was her clinical picture. Again, in both the eyes, the eyelashes were turned inside. There was congestion on the conjunctiva in the right eye along with epithelial defect. The anterior chamber was quiet. This was the clinical picture, which again shows this. We can see the epithelial defect with inward turning of the eyelashes. Again, for her, we have the same plan: electrolysis in both the eyes, along with application of BCL and the corneal topography in the later period. Her corneal topography also showed the signs of keratoconus in both the eyes, right eye as well as the left eye. So the lid abnormalities and keratoconus, what happens is, like, whether the patient has VKC or any other eyelid pathology, the patient keeps on rubbing the eyes, which triggers the which releases the interleukins and many inflammatory cells, thereby further increasing the eye rubbing. So VKC and keratoconus, the association is very well known. The prevalence of keratoconus is very high in patients with VKC, and also the keratoconus is more severe in these patients. Also, keratoconus has been reported with floppy eyelid syndrome. Patients with floppy eyelid syndrome, they might have chronic papillary conjunctivitis, which can cause excessive eye rubbing leading to keratoconus. Also, in patients with blepharitis, the keratoconus has also seen again because of eye rubbing. So the learning points from these two cases is, like, it is important to identify the risk factor that could predispose to keratoconus. The association of keratoconus with dystichiasis has not been reported. So this was the first case which has been reported. The early management of the risk factors and screening for keratoconus is very beneficial, and the treatment should include correcting the triggering factor which is causing ocular irritation and eye rubbing. Thank you.
Thank you, Dr. Pankaj. I think you've highlighted a very, very important topic and an often overlooked finding. When we have our residents, they are focusing right on the cornea, ye finding hai, wo finding hai, but they often miss looking at the upper lids. And I tell them that if you're not looking at the upper lids, you're not everting the upper lids, you're not seeing the contour of the upper lids, then you're never going to be able to treat this patient well because you're never addressing the basic cause, right? And floppy eyelid syndrome again is another often overlooked entity. We don't pay attention to it, and that's something which leads to chronic irritation and which has that. Thank you so much.
Thank you.
Hello, Dr. Pankaj. Did you do epithelial mapping for this patient?
No, epithelial mapping was not done. So when the patient presented to us initially, they were very symptomatic because of the surface irritation.
No, sometimes, see, epithelium is the most dynamic structure we
Yeah.
know. So anything irritates the epithelium, change the epithelium thickness.
Correct.
Sometimes that might be leading to the fallacious finding.
No, but the first patient, he had already the corneal scar in the right eye,
Okay.
which was indicative of he had eye drops previously.
Okay. Thank you. It's a very good presentation.
Yeah, thank you.
Very nicely highlighted, Dr. Pankaj. I think the point that you have noted is to always look for a cause, biomechanical cause, and we do find even in the absence of allergy or any lid abnormality, patients who are habitual eye rubbers, and the patients themselves don't realize it. So when we ask the question, we generally ask it in front of the family. So many a times the family themselves say that yes, he keeps rubbing his eyes,
Yes,
and
correct.
very vigorously, which the patient very vigorously denies as well.
Yeah,
So it's a very nice point that you have highlighted, and thank you.
yeah, thank you.
Sometimes patients will not give a history of itching, but you evert their lids, and you
Correct.
will see some papillae, and so you know that there is some allergy. So I would always rather overtreat the allergy in these patients rather than undertreat it, even if the patient is not reporting symptoms of
Correct, correct. Yeah,
itching,
yeah.
right?